Good morning. Get everyone signed on really quick, and we can get started. How's everyone's week? Good.
Very, very busy.
Busy.
It's been okay, thank you. How are you? How about you?
Good.
Fine.
All right. Let's see. And should we start on or connecting? So that's good. All righty. Perfect. Okay, so welcome everyone who is joining brand new or who I haven't seen before. And then also thank you guys for coming back, of course. And today we are going to actually be working on diagnostic imaging and dentistry, because that's what you guys have been working on for the last week or so. And then next week is going to be pharmacology. So I just want to let you guys all know that it's a prequel of everything. Anyone have any questions or concerns about diagnostic imaging or dentistry or both before we start, so that I can make sure I can touch on that, or hopefully touch on
Hi, Beth. Hi, everybody.
it. Hi.
It's Maria. How are you?
Good.
I'm finding this super helpful. I really appreciate it. I'm just a little bit confused. I figured out how to contact you, so that was helpful. Still, I started working on the safety on the IDEX. And it's just the one course that's 3 hours.
Correct. Yes.
Okay. I
just need to update that for you guys, because I know that they switched the course line as well. So that's probably why you're a little confused, is because
no,
they
and
switched
that
courses.
happens.
Yeah. So
Okay.
but yeah, it's technically a 3-hour course. I think when I took it, it didn't take me 3 hours, but they give you like 3 race approved hours for it, because it could take you up to that amount of time. So but I like it because it goes over all of the safety stuff that you should be doing, and not like what maybe some of your practices are doing. And then also like some positioning and stuff like that for you guys too. So it's just a good review for all of you guys, and just to kind of make some connections to those pieces. So.
Yeah, no, these are really helpful. So like I said, I took the test already and did not, this would have been so helpful. So I got through to I'm on the dentistry at this stage.
Perfect.
So, okay,
Perfect.
great.
No, that's good. Yeah, and I kind of set it up for all of you guys so that sure, it's like week by week and everything, but as you guys know, there's only like the 8 sections that I've sectioned through. So you do have those extra 4 weeks to kind of go back and do some of the other things that you might not have gotten a ton of time to do or anything like that. So don't feel like you are like in a rush to get through everything. Like, yes, 100%, I want you guys to be studying each week, and ideally 30 to 60 minutes a day would be ideal. So just do obviously the best you can, because I know everyone has like work and family and that kind of stuff too, but just as long as you guys can like set aside a little bit of time each day to do something, even if it's just watching a couple of videos or whatever, it will definitely help you and keep you motivated to continue. So
I wanted to ask, do we lose access to our program like after the 8 or 12 weeks is up, like when our test is scheduled? Like,
yeah, so say your test is scheduled maybe a couple weeks after the program ends or something like that, just contact me and let me know, and I can extend it out for you guys for that little bit extra time.
okay.
If you're not planning on taking the test till like December or something like that, that's where you might want to do an extension of the program, which you can do. So I can always send you guys that information on how to do that, but it's just as like if you guys were signing up for the test, and you just get then give them more time to extend out to work on stuff and all of that. So
Because my test is in August, and I know I chatted with you yesterday
oh yeah,
that I'm kind of struggling between trying to keep up.
yeah.
So, okay.
Yeah, so you're all being honest, so we can just let me know when your test is, and then we can just extend it out till that date or whatever.
Okay, thank you.
Yeah, of course.
Is this 12 or 8 weeks?
So this course is 12 weeks long, but it's sectioned out into 8 weeks essentially.
Okay, because my test is July 29th.
Okay, so you'll
So,
yeah, you will again kind of, just schedule it out until your test and stuff too.
yeah, and I'm doing the vet tech prep simultaneously.
Yeah. Yeah. I know a lot of people are, which is totally fine too, because I think that the programs are still so much different in the fact that there's just a lot of questions, and just seeing as many questions as possible to like kind of understand how the questions are being asked. And even though I have quite a few questions, I don't have the catalog that they have over all of their years yet. So I think that it's really helpful to kind of play off of what you guys are learning from each of you are doing both, of like how to bring both kind of together. So
Okay, thank you. I
Yeah.
appreciate it.
yeah. And for me, I felt like comprehension was probably one of the biggest concerns that I was finding with students, is that a lot of students are trying to memorize as many questions as possible, and then you get to the test and those questions aren't on the test. And so trying to get you guys to comprehend really the concept behind the question is really important too. So like if you see a question that you don't know, or even if you do know it, like try to pull out as much as you can out of that question and say, okay, well, even the wrong answers, right? Like what do those mean, or where do they come from, or why did they even put that in there, that type of thing, and try to comprehend what they're asking and just quiz yourself on that versus just like clicking a button and saying, oh, I got it right, now I can move on. So because you might not see that question again for a really, really long time. So it's like, okay, well, how can I get as much as I can out of this question so that I do know exactly what I'm talking about. So really kind of quiz yourself. Yes, it takes a little bit longer, but it'll be really beneficial in the end. And then, for me, I think the study sessions, the more that you guys come to with the study sessions and say like, I really need help doing this, I really need help doing that, that gives me a trigger of like where I need to go to kind of help you guys all together, versus me just kind of rambling on about stuff. And then you know, everybody learns a little bit differently. So that's why I throw in questions and I have videos and I have worksheets and all of that. So really play off of how you feel like you're going to learn best right away. And then you can always go back to do the extra stuff. So.
Thank you.
Of course. Okay, so for diagnostic imaging and dentistry, who feels like super, super confident in those areas?
Ah.
I got a few head shakes of no.
Not at all.
Yeah. So, and that's pretty common, I will say. It's pretty common that both of those are, and that's why I kind of stuck them together in a few different ways, was that we do have diagnostic imaging with dentistry. So that's another part of why I put them together. And many times people just get tired of studying one over the other for that long period of time. So I figured, okay, well, if I put them together, then people can kind of bounce back and forth and maybe not get super, super tired of this week. So, all right. So what I'm going to do today is I'm going to do this a little bit different than I normally do, but I felt like this might have been a good option before for people. I recently did a study prep session, so this is already kind of prepared, but we can talk about things as we go. There is, if you guys go to Mentimeter, so if you go to www.menti.com, you can follow along with this presentation, and then there'll be questions for you guys as we go through. So wonder.
Can you repeat that website?
Yeah,
Please?
www.menti.com.
Got it. Okay.
Let me. Figure out really quick.
Leave it.
All right, so now you should see the menti.com, and then to use the code at the top of the screen. So it should be 11083634. So when you get to menti.com, it'll ask you to put in that code. You can use your phone too. That's another way. That's kind of nice because you can.
Charlie. Sorry, I have a naughty kitten.
Use both at the same time. No, you're fine.
Beth, good morning. For this, I guess it's like a slide.
Yes.
Could we go back and see them whenever we want, or?
I can, for these guys, what I'll do is I will download it for you guys and then I'll put it on our Facebook crash course page, and then I'll also put it in Moodle for you guys too.
Okay, awesome. Thank you.
Yeah, because it is a little bit of a PowerPoint. It's a bit long, and I don't want you guys to feel like you are having to like write everything down or anything like that. So okay, so everyone has that code. Everyone's good. So get my stuff from before. So if you guys have questions, feel free just to like talk out loud. That's really fine. That's what I love. And then also, if you guys have the answer or whatever for something that I ask, definitely feel free to answer. It's okay if you're wrong, no big deal. And then we'll have some questions here and there that you'll choose A, B, C, D, and we'll see how everyone's doing. So,
Excuse me.
yeah.
What was the call for the Menti thing again?
Yeah, let me go back. So menti.com, www.menti, MENTI.com.
Okay. What
And
was the
then
numbers?
The
Oh,
numbers
sorry,
at
go
the
ahead.
top here, so 1108 3634.
Thank you.
Of course. I'll do is copy this link. I'll throw the link in. There's the link in the chat in case people need it. Alrighty. So, all right. So when we talk about the basic step of radiology safety, okay, so obviously, if we don't take care of ourselves, or we don't wear our proper safety material, that there can be obviously effects due to radiation over time. And so some of those things, like if we had radiation toxicity, you could see erythema from the skin. And so just redness of that skin. Other things are obviously cancer, and then cataracts as well. So you can have like radiation burns, stuff to that nature, and then cataracts are a big one, and neoplasia, and we'll talk a little bit about cataracts in a bit too when we talk about some of the equipment. So our sensitive tissues are, of course, all of where our blood is created. So obviously the bone marrow and stuff, hepatopoietic cells. So obviously where our blood is made, and where do we get like our epopoietin?
I'm sorry.
I'm sorry,
were the
erythropoietin. The
what were-
latent ones?
Yeah, sorry.
Cataracts and neoplasia.
Okay.
Yeah. So, so where is erythropoietin made from?
Kidneys?
Or the kidney is very good. Yeah. I'm like, where is it actually? Yeah. Where is it actually coming from? Yeah. So our kidneys. So a lot of times when we have maybe like renal failure cats, is like something separate, a renal failure cat, or even a dog that comes in, you may notice that they are anemic, and can be severely anemic. So that is because their kidneys are not functioning appropriately, and they're not able to produce the hormone erythropoietin to get those red blood cells in production. Okay. So it's very interesting how our hormones work, right? So yes, it's definitely, they're producing everything in the bone marrow, but we do need some cells to be able to produce that. So our epithelial cells too are really sensitive. Our intestines are really sensitive, reproductive cells, and then of course a fetus would be also very sensitive. So just keeping all of that in mind, those are the extra sensitive ones. Some less sensitive things would be like muscles and nerves. So if you have radiation done or anything like that, you're probably going to see more like burns and stuff like that first before you actually feel anything that's really deep into your tissues and everything. So ALARA, what does ALARA stand for?
As low as reasonably achievable.
Good, as low as reasonably achievable. Stuff's like, yep, we've done this before. So we want to protect ourselves. That's basically the concept of ALARA, right? Protecting ourselves, protecting our patient too, right? Which I can talk about in a minute. And then also, yeah, so it has three main principles to ALARA. So the three main principles that you guys should know or should have heard about before is time, distance, and shielding, right? So time really has to do with the reduction of exposure. So the reduction of the amount of times we have of exposure. So even though we have digital and it's super, super easy to take digital rads, and we can retake them 8,000 times, we really shouldn't, because it's still going to produce the same amount of radiation. So trying to do the best as you possibly can to get it perfect on the first shot would be not just time nice or whatever, but also so that we don't have a crazy amount of radiation that's going up. And then distance from the source would be coming from a lot of different things. So people tend to think right away that distance is just mainly like, you know, hands-free radiology, which is 100% true. Like if we can do hands-free, that's fabulous. I know that there's a bunch of, well, a couple states now that are really working on getting that. I know there's a bunch of corporates that are working on trying to get that too in place. However, some other aspects of distance would be like collimating your patient down to where it needs to go. So how many of you guys do catograms and dogograms? Probably more catograms than dogs, but
We try not to, but sometimes it happens.
sometimes it happens, right? Yeah. And so really the big part of that is that if we are truly looking at, there's a couple of things. If we're looking at exposure, right, we're exposing both areas of that patient to radiation where they might not need it, right? And just because you can do it because they'll fit on the plate doesn't mean that we necessarily need to or should. If it is needed, there's a couple different things that you actually, by collimating it down and focusing it on one specific area, you're actually going to get a better image than if you open it up to both areas, right? Your abdomen is going to be a different setting than your thorax, right? And your patient normally isn't a cube. So they are going to have those different measurements that we should be like looking at too. So your abdomen might come out too dark or your chest might come out too light if you're doing those big shots. So for the doctor's sake, outside of ALARA, it's better if we do a chest image and then an abdomen image, so that they can get a nice view of that picture. I know a lot of radiologists who will come back and say, hey, you shouldn't do catograms or you shouldn't do dogograms, you know, you should get a better image. But then I also know there's a lot of veterinarians that are like, oh, just do a catogram. And you're like, that's, we shouldn't really. So best standard of practice would be to do 2 separate images so you can get the best image as well. So also distance from your patient can be, you know, if you can't do hands-free, right, is trying to use as many devices as possible to be able to stand back as far as you can. So especially like limbs and things, like how can you stand back a little bit further from your patient, and also take a good image, you know, by using certain types of ties and stuff to hold the leg out versus putting your hand right there, right? Because we all know that most people aren't wearing gloves when they should be, correct? I think I read a study that said like 98% of the veterinary profession doesn't wear gloves, and mainly because they're really hard to use. So Does it make it great? No. But hopefully over time we can see that there is a benefit to wearing gloves, and that we can get some gloves that are easier to work with for our patients. And then also, you know, in combination of hands-free and all of that, we can do that. Using a radiation shield. So a long time ago, we used to actually have a lot of lead shields that we used. So like if you were taking an image, like you would try to stand behind that shield as much as you possibly could. With now having digital, they don't have necessarily a shield that's like built into your radiology machine. So they do have other shields available. So like say you guys are taking dental rads, right? And you might not have space to like move completely out of the way or whatever. Yes, you should be wearing PPE regardless if you're like working with that patient, but having shields around that patient, like lead shields, is really good. And then positioning devices and accessories. So we talked a little bit about accessories. So we used to use like wooden spoons and stuff to hold the foot down. You could totally do that. Tape is really great. There's Velcro straps on your troughs as well that you should be able to use for legs that a lot of people don't know about. And then using troughs as well, and wedges and different things. Okay, so they're super, super helpful. And then sedation or anesthesia for patients can be extremely helpful, especially if you're trying to do limbs or spine or skull. 100% you have to do. I don't care what anyone says. In order to get a great skull rad, you need to have them sedated or anesthetized for that. So with all of those things, right, we should be able to reach that as low as reasonably achievable. Okay, so yes, we aren't necessarily to the end of where like human medicine is, because our patients don't sit still for us, but we are getting better to that. We can step away from our patients a little bit more the better we are getting with using some of our accessory and positioning stuff, our sedation and anesthesia. And then when we can't, we really need to be putting on as much PPE as possible to protect ourselves. So this just like kind of goes over obviously the time aspect. So collimating things down so that we have things directly onto that plate or film. And that scatter is spread outside of that collimated film. So if you have a bigger opening, that's going to be your direct beam. And then there's going to be that more radiation, right, coming off and bouncing off and scattering even more than it necessarily should be. So if you're doing a limb, collimate it down to where it needs to be so that you can reduce the amount of scatter that you're going to see, and the primary beam too. So. And then setting your time on your x-ray machine as low as possible in your milliamperage per second. So that again is going to be how much power of that x-ray that's coming out per second. So we have to do the best that we can to make sure that it is, you know, to a good setting. And then minimize the time that we're actually in that room during exposure, or the amount of people for radiographs, right? So typically we'll have a max of like 2 people, but then there are times where you might need a third person to come in and help for like maybe a bigger animal or something. But if you are really struggling with a patient and you're needing that third person because you're struggling, that's when we need to start talking about, hey, maybe some sort of chemical restraint is going to be helpful, even if it's just a little bit. Okay. So distance. So making sure that we are outside of that primary beam, number 1, and then as far away from scatter as possible. So you guys should know what the inverse square law is, or have heard of it before. Anyone familiar with inverse square law? Or kind of have familiarity about it? basically saying that the intensity of your x-ray will decrease by the distance that it's going from the primary beam. Okay, so if you say stick your hand right up to the tube and take a radiograph, it's going to be that intensity on that one area is going to be pretty intense, right? But the further we're away from that primary beam, it will decrease that intensity to the tissue that you're using. So whether it's your hand or anything like that, right? So on that specific area. Okay. So as that distance goes through, it will double right away, and then the exposure changes, or I should say the intensity changes by a factor of 4. So just kind of review that, but it should make sense to you guys as we get further down. It's kind of like a cone shape, right? That yes, it's going to be really intense right where those x-rays are coming out, but as we move further and further down, the intensity in that one area is not a direct beam, right? It's not directly on that. It's coning down onto our plate. Okay. So keep that in mind. All right. So for distance, using the non-manual restraint radiograph stuff. So again, where you're able to maybe, like I say, tape down a patient, but if you guys have ever seen hands-free things, many of them use like sandbags, and then they also will use some tape too, just to put on pressure spots of an animal. So there are a lot of animals that you would think that you wouldn't be able to actually do like hands-free with. However, if you learn a lot about the pressure points of where animals feel comfortable and stuff like that too, they actually will sit there most of the time. And then if you can't get them, you can always use, you know, some chemical restraint too. So I actually was in New York and saw them doing x-rays on a Rottweiler, and they did both the laterals and the VD chest, and no one was holding the patient, and there was no chemical restraint or anything. It was pretty cool. So, and they just used some sandbags and some white tape.
Well, the video that you have up on the hands-free, she's amazing.
Yeah. Yeah, she really is.
Yeah, that was.
And it does take a little bit of patience, right? Like, and we're probably not the most patient when we're really busy and stuff like that too. It does take a little bit more patience to get them down into that position and stuff like that. However, most of us our ideal would be to be in this field for quite some time. And so over time, the more and more radiographs you take and the more that you are exposed to radiation, the worse it is for you, right? Regardless of the amount of protection that you do have, like you still have been exposed to radiation, right? So the more we can preserve ourselves, the better that will be long-term, okay? Because nobody wants to have like painful hands or thyroid issues or cataracts or anything. And you cannot save your eyes by turning your head away or closing your eyes, okay? That's actually a common misconception that we have. And I actually had one person say that they learned that in tech school, was that if you turn your head away, that your eyes are going to be somewhat more protected. And I was like, that's absolutely not true. Like scatter goes everywhere. It really does. Within that room, it's going to bounce off your patient and your table and everything, and it will travel around the room. So it's not protecting your eyes. Now, there is something that can protect your eyes that we should be using. And what is that?
Goggles.
Good. So yeah, lead lined glasses or goggles. For sure. So are they the prettiest things in the world? They're not super fashionable statements, but they are going to protect your pretty eyes so you can see long term. So they actually have some that aren't that bad. So, but you're not going to be going and walking around the whole practice with them. So And especially if you're working in radiology, so there are people who work like strictly in radiology should be wearing their protective equipment all the time, especially lead line glasses. Now, some people say, well, like my hospital doesn't have, you know, lead line goggles or glasses, or we only have one set of gloves and they, you know, they suck and they're like from like 1980 or whatever. It is the responsibility of your hospital to get you guys equipment that is going to protect you. So that is like a big OSHA violation if they don't have the protective equipment that you are requesting for yourselves. So if you guys need, you know, those glasses, if you guys need gloves that you're able to use and work with, like those are things that they are required by OSHA to be able to get for you to protect yourself.
And just so, oh, and
Yes.
sorry, if I could just kind of interrupt, I've been in the field for like quite a while.
A
And
hot minute.
yeah, and this is actually pretty scary, and it makes me cringe now, but like when I started 25 years ago, wearing aprons, like the lead gowns, was an
Yeah.
option. They didn't even like push it. But
Mhm.
one thing to check that this I have definitely seen get dropped by the wayside
Yes.
is to check your gowns by taking x-rays of them, because if the lead is cracked, you're not protected.
Yeah.
So to pop them on the x-ray machine and take an x-ray of them to see if they're cracked. Because
Yeah.
if they are, they need to be replaced.
Yep. No, and that is a great point because a lot of times we'll have, you know, lead will do well for quite some time if you take care of your gowns. However, we are always in a big rush to do things and you know, we'll pop our x-ray gowns like right on the table or something and come right back, right? And you're like, oh my gosh, Beth, how do you know this? I do, because I worked in the field too. I know that we do all this stuff. But if we crease those gowns, if we fold them over, that lead is not super moldable. And so it can crack, or you can get some holes in it and stuff too. And even if it's a tiny, tiny little crack, you know, you might be like, oh, it's not that big of a deal. It's right by the collar or whatever. No, it is, like, because it can get through that gown. So you have to replace them. Now, they do have, and maybe some of you guys have seen some newer ones that are made from Bloxar. So it's BLOXR. Those are actually made not with lead. They're made with a chemical that protects you from exposure. So that's why when you put them on, they're like super lightweight. I actually really like the gloves because they're lightweight and they're like a little bit more moldable. What I also like about those is that you can wash them in your washing machine and stuff. So like, how many of you guys have lead gowns at your practice that have probably been there for 20 plus years, and truth be told, like they've never been washed? So how many people have worn those gowns and stuff and they get pretty gross? So that's kind of why I like those. You can still x-ray those, but the best way to check for the Bloxar ones is to do fluoroscopy on them. But you can, most people don't have fluoroscopy, so you can just x-ray those guys to make sure that they're holding up as well too. They are going to be a little bit lighter in color when you do x-ray them, so don't get like freaked out because they're not lead lined. It's actually like more of like a jelly type of thing inside. And so I really like those. But you are absolutely right. Now, how often should we at least be checking our PPE?
Every 6 months.
Very good. Very good. So in human medicine, and that's why where some people get kind of lost in that, is that they think that, yes, we should be doing it once a year. In human medicine, and the OSHA standards and stuff like that at the time were once a year for everyone across the board. However, for us, because we are literally in the room all the time, we're putting the gowns on and off and moving them a ton, versus like in human medicine, they don't necessarily need to use the gowns and other stuff quite as much. That's why they can kind of get away with doing it once a year versus us, where we should be doing it at least every 6 months. Now, I do have some people who do check them every quarter just to be like on the same schedule as their dosimeter badges. And that's totally fine too. Like you can't over check your gowns. So, but you are absolutely right that that gets forgotten quite a bit. There are some people that use like ways to record that stuff too, like whether they have like Avamark, they'll put like PPE in as a patient and then like write in what they've done and keep track of it that way, so they can have like reminders come up and everything. And then, you know, other people still do, you know, old school charts to just say, hey, we did it this month or this month or whatever. So whatever works for you guys. So shielding, so making sure that we, if we're present in the room, that we are being shielded with the proper PPE equipment. So it has to be of 0.5 millimeters of lead equivalent, as much as possible. So you may see like 0.25 millimeters of lead equivalent of lead some places, but in order to have like the proper PPE, it has to be that at least 0.5 millimeters of lead equivalent. So wearing our thyroid shields. So I love that you said that gowns were optional at one point. And yes, that's true, especially like I said, how they had that lead partition there, but even you're still in the same room. So it just, to me, my mindset was like, that just seems so weird, even though I know the lead is supposed to protect me. It just seemed weird. And then thyroid shields were most definitely almost never used and 100% like optional at that point too when I first started. They of course encouraged you to wear thyroid shields, but it was definitely not one of those things that people did on an everyday basis. And what they were finding was a lot of people were coming back in and having thyroid issues, whether it was like thyroid carcinoma or other thyroid issues. And then they were like, oh, okay, well, we really need to get on this. So we've gotten a lot better with thyroid shields. And gloves are definitely one of those things that I think we're going to be in a constant battle with people about. But I can say that our hands are going to be the closest to that primary beam, right? And so we really should be protecting them. And when you protect them, it's not protection if you just put the glove over your hand. Like some people just put it like over your hand versus the glove on. So scatter, what happens is it bounces off the patient or bounces off the table, and then it can go anywhere. So if you just have the glove over your hand like this, or you have the ones that are just the mitts, so they have just this side, which I don't know why they sell these, but they do. And then this part of your hand is open. So if you are using them, the scatter can bounce off the table or bounce off the patient and then go underneath and hit your hand too. So it will hit the underside of your hand. So you really should be wearing your gloves. And then lead glasses. So lead glasses have definitely been a thing to really start pushing more and more. And it's because we didn't realize how sensitive our eyes were. And so they can actually not take as much radiation as the rest of our body can. So we really should be protecting them, and we don't protect them at all. So like I said, closing your eyes, turning your head is not going to be helpful for you, but putting on those lead glasses are one. And then when all else fails, having those standing shields or stepping out of the room, that kind of thing is going to be really helpful. The more distance you have from the patient, the better, right? Because the scatter is going to get further and further away, and you're not going to have quite as much of exposure. So lead shielding, we don't have any like protection for our actual patient. And even if you wear a lead glove, remember, and you put your lead glove into that primary beam, it is not going to actually protect you. So that radiation will go straight through that glove. So your shielding is only protected for scatter radiation. Okay, so we've all probably seen some horrific radiographs where you see hands and stuff like that inside the primary beam. Those are from people not wearing gloves. But even if you put your hand with a glove into that primary beam, it will still not be protected. So carrying and storaging of that, remember that lead is really delicate. So we want to hang it without any creases, or you could store it flat too. That's totally fine. Just don't like fold it over. And then we want to check your PPE at least every 6 months. I do have a recommended exposure aspect that you can use for that. However, you know, most of the digital stuff will take care of all of that for you too. So, but you're really radiographing the whole entire gown. And so you're going to have to do multiple different ones. And then you will do like your thyroid shield and your gloves and everything too. And anything that has like a little, even a pinprick in it, you want to get rid of, discard of, and get new equipment. All right. So my first question, the minimum age for a person to be involved in radiograph procedure is, and then you can go ahead and put your answer in from your, whether it's your phone or your computer. Maybe some of you remember this from when you were this young.
It's been a long time.
Yeah, I was like, it's been a long time for me, but I remember it because they threw a party for me. So, because they were like, good, you could take radiographs. All right, very good. So it's 18. Perfect. So you have to be at least 18 in order to take radiographs. So yeah, for myself, when I turned 18, my hospital like threw me a little party and they were super excited because I can finally take radiographs. Now, the other thing, so say you have maybe a 16-year-old that's working at your practice or whatever, they can obviously do other aspects of that radiograph stuff too. So whether it's like setting up and doing that stuff, they just can't take the actual radiograph. They can't be exposed to radiation. So for myself, this was back before digital came out. I would actually process the radiographs as people were taking them because again, that took a little bit extra time. So if they needed the cassette to take more radiographs, I was that person to like go, you know, process the radiograph, put a new film in there, give that back to them so that they could go take more radiographs too. So it's definitely not that thing where you have a 16-year-old and they go, oh, well, I don't have to go anywhere near radiology. No, make them do some of the process, right? Because they will turn 18 at some point. And then when they finally are 18, then they can actually be a part of like actually taking these radiographs. So, and the same thing was like when I was pregnant too, like obviously I didn't take radiographs, but I helped with like setting up that stuff, getting it ready just so that the people that weren't pregnant could just go and take those radiographs. All right, so if an employee's dose in the calendar year exceeds a certain amount, we definitely have to back off of them doing radiographs, right? So we do check dosimeter badges every 3 months, so it is quarterly. And everyone is able to see what their dosimeter reading is at. So even if your boss is like, hey, you know, everyone was good this time around, you can actually still say like, hey, can I just see what I'm at? Like, I don't know. I mean, most of the time it's very minuscule. But some people really want to know. And so that stuff is free for you to be able to access at any point, right? You should be able to see that. And then if you are going to another job afterwards, it's important that you transfer over that particular like dosimeter reading and all of that stuff to your next job so that you have a lifetime of knowledge of like where your body has been exposed to radiation, right? So nobody told us that when I was in school, or, you know, we didn't learn that. So I had gone from job to job and never transferred my information. So I probably have like 10 different dosimeter badges out there really, and I have no idea what my like total reading is. So, and then, remember that our occupational people have to be at least over 18. So here are our doses, all right? So for a whole body, the annual dose in millirems is 5,000. Okay. And then if you look at fetus here, fetus is 500, and yes, it says annual, but hopefully no one is ever pregnant for a whole year, right? So that would be in the time that you were pregnant for. So we do have a little bit difference in how we handle people who are pregnant that are taking radiographs too. So you'll have a fetal dosimeter badge as well as your regular dosimeter badge. And that fetal dosimeter badge is submitted every month to check and see what, how much exposure the fetus has gotten. Okay. And if you notice, the lens of the eye is 2,000 millirems. So that is definitely a lot less than the whole body. If you look at extremities, it says 50,000 though. So why is extremities? Why do you think that extremities are so much higher than whole body?
Because of the bones, the density.
Good. Yeah, our bone density as well as, you know, muscle density and stuff. And remember in the beginning, I said that, you know, the less extreme stuff is going to be our muscles, nerves, and then of course bones. So yes, those are our annual dosing on that type of stuff. So the lens of the eye, we currently, a lot of people are not wearing glasses, lead line glasses or anything like that. But again, it's really, really important that we do, because our whole body is 5,000, yet we're covering quite a bit of our body, right? But we're not covering our lens of the eye. So protecting our lens of the eye is really important. So if you're pregnant or you know someone that's pregnant, of trying to avoid exposure as much as possible. Having those fetal dosimeter badges, they should be having less than 55 millirems every month, and then no more than that 500 millirems in their entire pregnancy. And the most sensitive time for exposure is during that 8th to 15th week of pregnancy. So why do you think that the 8 to 15 week is super, super important?
It's when most of the growth occurs.
Yeah, it's like some of the major growth, and a lot of growth is occurring during that time. So, so yeah, if we know that we're pregnant or someone knows that they're pregnant, making sure most definitely that they are limiting their exposure, especially during that first trimester, would be amazing. And then, so tips to remember. So positioning is really important, right? And then getting the region that we really want into the center of the beam, and collimation is a critical thing to know, how to collimate down and all of that. Aligning your x-ray tube and the film plate, and then correcting the focal film distance. So if we need a tabletop versus a regular film, like where those focal distance points are at, and then proper exposure techniques based on each body part and size. So we'll talk about how to change your KVPs and then your MAS as well, to make sure that you are having that proper exposure. So the KVP setting on an X-ray machine controls what?
I always get those mixed up.
All right. So if we look at this, we have still some people. If we look at this, what is, okay, so nobody chose focal spot, so that's good, right? So even if you don't know this question, like even if you don't know the answer, looking at all 4 of these selections is really good. So focal spot size everyone was good with, right? Because that's going to be more of our collimation, correct? Now, number of electrons emitted and then quantity of the X-ray beam, it should be beam, not beams. These are very similar in an answer, right? So quantity of the X-ray that's coming out of the beam and then the number of electrons emitted, right? So it makes you then question, like, why are there 2 very similar in here? And then quality of the X-ray beam is how well things are penetrating in the tissues, right? So the the quality of it. So I think of KVP as the P part of KVP is penetrating of tissue, and that is going to be the quality of your X-ray, right? It's going to show you like a little bit more, you know, when you're looking at your patient, it's going to show more definition and stuff like that. It can be too light sometimes, right? And then we have to change it. It can be too dark, we'll have to change it. But when we get it correct, when we get it right, it's going to show you that quality of the picture because you're penetrating the actual tissue. And then we'll talk about the next one in a minute. All right. So, so having a technique chart, most of you guys have a technique chart already of some sort. So we used to have to make our own technique charts, which was always fun. But now most digital radiographs have come with their own technique chart. They've done that for you. And then you kind of just work off of that. And some of the technique charts are super, super easy to follow. And then even if you don't get it correct, the digital rads, as long as you're somewhere close, it will auto correct it for you, which is nice. So you don't have to retake your X-ray. Collimation, again, is important. You'll hear me say that a million times. So use a higher KVP technique to lower the MAS and decrease radiation levels. So that means that if we want to get a good picture of like things that are penetrating the tissue, we would rather use a higher KVP to like penetrate that tissue rather than a higher MAS, because MAS is going to be, remember, the amount of X-ray coming out of the beam per second. So it just depends on how long that second is or anything like that, but it's going to be a lot of the, again, X-ray coming out of the beam for you. Okay, so MAS determines the quantity of radiation per second, and then KVP determines the penetrating ability to the tissue. And I say tissue meaning whatever, it could be that we're checking a bone or we're checking an abdomen or whatever, but all of that meaning the same. Okay, so now let's see. So MAS, so milliamperage per second setting on an X-ray machine controls what? Yay, good. So quantity of the x-rays emitted, very good, right? So this means that how much x-rays are actually set off for our x-ray. Okay, very good. So if any of you guys have seen Lower the Dose, this came out 2018-ish, I want to say, but it was an initiative done by NAFTA and the American College of Veterinary Radiology to, again, bring more education and stuff to radiology. So if you go to like lowerthedose.com or whatever it is, it gives you a lot of this information too. So, and they have posters and stuff that you can use and things for your practice. So it was a really good initiative to start. So the x-ray process, all right. So we have our anode and cathode. So this is like the very beginning of radiology when you guys learned, right? So how the actual like x-ray tube works and all of that. So we have our anode and cathode. The anode is the positive end because you're getting an A+ for doing so good, anode, and cathode is negative because cats are negative, right? So that's how we remember those things. So they're enclosed in a vacuum, and then in this like glass envelope, surrounded by lead housing. So, that way it can contain, you know, all of that radiation that's starting to happen. So the filament of the cathode gets heated up, but it doesn't melt, obviously. It doesn't melt anything because it's made out of what? You wanna know?
The thing that starts with a T.
Good. Yeah.
That's as good as I get.
Yeah, tungsten, right? So it can basically not, it's not melting because tungsten actually can absorb a lot of that heat. So so electrons boil and form a cloud within that focused cup, and it's accelerated out through that vacuum onto our target on the anode. Okay, so when it has this collision, it creates that heat and energy, and that's where you get those x-rays from. So we have that small window that you guys see on your radiology table, and that's what allows those x-rays to leave the tube in order to get your picture. So that is in a nutshell what all of that means. Okay, so to produce x-rays, a great deal of energy in the x-ray tube is converted to heat. The ratio of heat generated to that x-ray production is what? This is really interesting. So we have energy to heat, or essentially how much energy and heat is needed to produce that amount of x-ray. So how much of that energy / heat do we need in order to produce x-ray? What is our, if you don't know, it's fine, just guess.
Got a 1 in 4 shot.
Exactly. This is actually really interesting. Ooh, you guys didn't do that bad. Good. So most people do choose somewhere between the 99.1, 99 to 1 or 75 to 25, just because of process of elimination, I think, even if you don't know. So very good. So it actually is 99% of that energy to heat, and only produces a tiny bit of x-ray. So if you can just imagine how much then heat and energy is really needed to produce the x-rays that we want, right? So it is pretty just interesting bit that you might see. So just know, like, we are actually producing a minuscule amount to the amount of work that your x-ray machine is is heating up and whatnot. And this is why it's important to you to always have your x-ray machine double checked and stuff like that as well, because what if something's wrong with your x-ray machine? You could be getting a lot more x-ray. Okay, so the heel effect is going to be more noticeable with what? Anyone heard of the heel effect?
Yes.
Okay. All right. Oops. So it is a larger film and shorter focal spot distance, okay, with a lower KVP. So this means maybe we'll have a larger film and our focal spot distance is shorter on the scale thing. So maybe we're not using a tabletop or whatever, but we bring down our machine closer to the table, right? And then we have a lower KVP. So where it's not penetrating the tissue as much. So you might have some part of that area not penetrating very well, and you might have another part of the area that is penetrating a little bit better. So I think of like a chest a lot of times, because chest can be, you know, two different measurements depending on what kind of animal you have, right? And so maybe the part of the body that is a little bit larger, if you have that smaller focal spot, or I'm sorry, the distance of the focal spot down on accident or whatever, and you're using a large film, you might see that that is a little bit lighter than maybe the bottom part of the chest when you're looking at a lateral, okay? So that's why it's important to have like our focal spot distance appropriate for each patient. And also, if we are using a larger film, again, collimate down to where you need to be collimating down to, so that we don't have these weird like density issues. And then the catagramms and stuff, like I said, are not a perfect thing because you can get that heel effect.
So this is so hard for me. I do not work in the field.
Yes.
And it is so hard for me because if I was doing this, I think even for a week, then I would get it. So hard.
No, I can completely understand that. I was, again, very lucky that I worked for about 5 years before I went to school. So like, and then I worked while I was in school. So taking everything that I did when I was in school and then bringing it to work and like practicing all of that stuff was really, really helpful. So I can't imagine how it is to just try to put all the pieces together without actually doing it, because our job is so hands-on. It's so
hands-on, right? I mean, I shadowed my vet for a while, and they were amazed because I was just checking out the x-ray machine and figuring out where the cathode and the anode and the things were. I mean, that's where I'm at with it.
Yeah. Yeah. So I think, that's one thing, is to just, if you can, go and practice those things and take some time to like check yourself and be like, okay, can I do this? Because I think we take it for granted sometimes that we do have these things available to us. And when we are working in the field, that, you can practice on days that are,
And I also think that the vet assistants that are working out there who are not licensed yet are not given enough credit. I mean,
yeah, no, absolutely.
They do so much,
And Maria, if it makes you feel better, just because you've been in the field a long time, you can go through the motions and know how to do it, but not understand it.
Yes.
And so, because that's, I've been in the field since 1999, and I did about 3 years of day practice, and then I moved to emergency and critical care. In the past year, I've been doing toxicology, and so I've really only been hands off for less than a year. And I still feel like I've lost so much. But even though I went to school eons ago and never took the test because over 20 years ago, it wasn't a big push to be licensed. And now it is, especially now that I'm transitioned over to doing pet poison. But even though I can do all the motions and can adjust the things, I've never heard of the heel effect. So don't be discouraged that you haven't been in
I'm
the
not.
field
I'm
yet.
not.
So because it certainly does help. I can't imagine not, having the experience, but just because you go through the motions doesn't know that you understand the terminology.
Yeah.
And thank you for saying that, because I found, I did 2 externships, and when I asked questions about, bisecting in parallel and heel effect, and they looked at me like I was crazy.
Yeah.
And not everybody is an educator or is willing to take the time to educate you. I'm an adult, so I ask a lot of questions, and I'm going to continue to ask a lot of questions, because animals' lives are at stake. So but thank you for that. I appreciate that.
And I think that's a really good point, because we do have, really great people out there who are not licensed, who have been doing things for 20, 30 years, and they know their jobs like to a T, right? And I think when sometimes we get some comparisons of maybe a new CVT comes in versus, someone who has been on the job trained for X amount of time. And I see this a lot on social media of like, well, I'd rather have that person, that's been on the job trained for this amount of time because they know how to do everything in the practice. Well, you're absolutely right. But what did they know how to do when they first came in the door? We have CVTs who are just graduating who may, their experience is so different. And this is where we get diversity, right? And so diversity means that it's not just based on, like race and all of that, but it means that we're just different people. And so having a CVT come in that's brand new, compared to someone who's been on the job trained, like, can you imagine the amount of knowledge that both of them can share with each other and become both truly, truly amazing? So I think that these are things that are not comparable when we're talking about this stuff. And it's just like having a new grad doctor come in the door versus a doctor who's been in the field for 30 years, right? Like, we really need to have those people collaborate with one another, because guess what? They're both going to grow from the experiences of one another. So I hate seeing those posts. I hate seeing when people are like, well, I'd rather have this and I'd rather have that. And I'm like, I'd rather have both. Like, let's bring them together and have them work together. And as long as people are always willing to grow and learn and not say like, I've done my job for this amount of time, so I'm good, or say, well, I'm not doing that because, they're not, a certified tech or whatever. Like, we can't have that. Like, leave your egos at the door, get to work and get to learning, because it's only going to help you and your patients. So,
and there's always more to learn.
Yeah.
And there's
really
different ways of doing things.
Yep, most definitely. So this is what the heel effect looks like. I know it's a terrible picture because it had to be blown up a ton, but our cathode is back here and our anode is over here. So we have our filament right there. And essentially what's happening is you have this thicker part of the body here. So we're going to have more, it's just going to show like that we do have more of that radiation coming out over here versus here normally. But if you bring your table down even further, it can make it so that we are penetrating not appropriately to our patient, especially in the thickest part versus the thinner part of the body. So just keeping that in mind. All right. So, when using a direct safe light system, the distance from your workbench should be what? So this would be like if you are if you're turning on the light, so that's what they talk about safe light. If you're turning on the light on your the distance from your workbench should be what in the amount of inches. So if you're not doing a tabletop, you're doing just a regular. Ooh. So 48 inches away. So this means that we need to have our workbenches at least 48 inches away from when we're doing any type of x-ray. Okay. Okay, so milliamperage. So this controls, again, the electrons that are boiled off into the filament and all of that. Typically you'll see those numbers be in the hundreds. So whether it's 200, 300, 400, 500, that type of thing. And then when you see milliamperage per second, that means how much of those milliamperage is coming out in the amount of seconds. So sometimes we'll have our seconds set at like, 1/60th, right? And that's where we get our milliamperage per second. Okay, so it means milliamperage is the amount of electrons making up that x-ray that could be coming out soon. And our per second part is how many are coming out in a second worth. And then we essentially are not going to be taking our x-ray in a second. It's like a very tiny amount of seconds, right? So many times you'll see like 1/60th of a second, 1/30th of a second, 1/20th of a second. So you'll set those. Again, a lot of times your digital x-rays are already kind of set for you. You only have to put in your milliamperage per second and then your kVp. But if you guys are using some really, really old machinery, you will actually have to set each one of these things. So you'll have to set the milliamperage, you'll have to set your kVp, you'll have to set your seconds, and then it usually calculates for you your milliamperage per second. But we're going to learn how to calculate that. So if a radiograph is too dark, but the image shows adequate penetration, you should do what? So your radiograph is too dark, but we have adequate penetration to our tissue. So what should we do? This is a big one that people have a hard time with too. All righty. See, we're like divided everywhere. So if our radiograph is too dark and we have adequate penetration, okay, so the penetration to the tissue is fine. So if our penetration of the tissue is fine, which of these can we actually get rid of on our 4 options?
KVPs.
KVP, right? So all of a sudden we're like, good. Our KVP is down, like we don't have to worry about those 2. So now if our radiograph is too dark and we need to do something about that, right? So if it's too dark, I compare it to toast, right? So say we're making toast and our toast comes out too dark. Are we going to turn up our heat and put it back on the toaster again, or like make a new thing of toast? Or are we going to turn down the heat to get a perfect thing of toast, unless you guys like burnt toast.
Down, right? Decrease.
Turn it down, right? Yeah, very good. So, same thing for our radiograph is that we are going to, if it comes out too dark and we need to retake it, we need to turn it down like toast, right? We want to toast our radiograph. Perfect. So we would turn down our MAS. Okay. Now turning down your MAS, or you turn it down to 30 to 50%. That's like our guidelines for it. And then for KVP, it's the same thing. So say your background of your radiograph looks completely fine. And that it just looks like you penetrated that tissue way too much. Think of it as toast. Okay, I over toasted my radiograph in this area. The KVP is the penetration, right? So I over toasted it. So if I'm going to toast again, I need to decrease it, right? If it's too dark. All right. If it comes out too light, then we need to turn it up because we didn't toast it enough. All right. So if you guys are really bad at making toast, maybe you'll be better at doing radiographs though. All right. So in this one, we are decreasing our MAS. Very good. All right. So exposure time, kind of what we talked about, is a fraction of a second. Okay. That we are going to be eliminating those x-rays onto our image. And so you'll see that. So for this, if you want to confirm that you have set everything correct with an MAS of 15, which of the following scenarios would give you an MAS of 15?
Oh, this is that math question.
Yeah.
I think you answered this for me on Facebook.
Oh yeah, I think so.
Yep.
Or something, yeah, something similar to that.
See, I remember. Not the first one. Sorry.
So remember what our milliamperage per second is, right? It's milliamperages per, meaning divide, by second.
I think I got it. That's how I learned, by making a mistake.
Yep. All right, let's see. All righty.
Yes.
So the answer here is the 300 MA with the 1/20th of a second. So if you are going to be doing this problem, right, you are going to say, okay, my 300 per second. So it would be, you take 300 times that point, or I'm sorry, 300 times 1/20th, or for myself, I just take 300 divided by 20. And that should get you your MAS of 15, right?
Yep. Yep.
So if we have the 150 MA with the 1/15th of a second, what would your MAS be?
Say that again.
If we had this third option here, so the MA is 150,
Oh.
and it's 1/15th of a second. So what would our MAS be?
10.
10, very good, right? So we think that it's much harder than it really is. So this first one here is 300 MA and 1/10 of a second. So what's your MAS?
Higher, 330.
30, right? So that's pretty high. And remember, 1/10 of a second is longer than 1/20th of a second, right? So we have it set for a pretty high MA, so the amount of x-rays, and then we're having it like come out of the tube for 1/10 of a second. So that's a lot of radiation compared to this one. It's a little bit less radiation. And then 150 MA with 1/20th second. What do you guys get?
7.5.
7.5, very good. All right, so same thing here, like for the 150 MA, we don't have as much radiation as the 300 or electrons, right, that are coming off. But our 1/15th of a second is longer than the 1/20th of a second, right? So this one would give off the least amount of radiation out of all of them, most likely, yes, because it's the MAS is 7.5. And then from there, we figure it out. Then it's this third one, then second one, and then first one. About the most. Okay, so DICOM. Has everyone heard about DICOM?
Yes.
Yeah. So it's the way that we communicate our digital radiographs with other individuals. It's universal throughout. So we can take pictures of our patients and then we are able to send it off to have it read, and it's just makes things a lot easier to also house all of the images that we take and stuff like that too. So it has the image and the patient information, what modality we use, like the time and date of the exam, stuff like that, and then any formats and stuff like that that are used are on there. So this is nice for like if we are sending out images from different computers. So if we send out an image, someone else can get that image at a different computer. So if you have a radiologist or whatever that's not in-house, you can do that. Now a RIS, so RAS, we say RIS, is software program to coordinate all of the patient's data to other hospital forms and records and stuff. So this allows us to like cross internet paths and private practices and referral centers everywhere with specialists, especially since there are a lot of radiologists now working outside of hospital settings, so they can receive images and interpret them and send back a report pretty quickly. So you might have both of these programs within your hospital in order to send out images and stuff like that. So if you ever have someone say, hey, you need to complete the RIS form for radiology stuff, that's what they mean by that, is that you need to fill out like the actual form to be able to send the images from your DICOM to the radiologist so that they can complete their component and send that back to you. So their exam and stuff from those radiographs. That makes sense. All right. So you notice that there's a clear line at the top of the edge of your radiograph and you have manually processed, okay? So maybe not a lot of you guys manually process things. But there might be some who have done like x-ray stuff and whatever. I'm sorry, dental x-rays I meant. So you notice that there's a clear line at the top of the edge of the radiograph that you manually processed, okay? So this would be due to the area not being what? All right, let's see. Oh, very good. Developed.
It's a good guess.
I'm like, we have more people who have done some manual stuff than I thought. So, okay, so why is it developed versus collimated?
Well, I guessed, but I would think because it's clear.
Okay.
I mean, that's, you know.
So if you collimate down your image onto a film, okay, that you manually process, whatever you've collimated down is not going to develop on that, right? So that will also be clear, but will it only be clear at the top of your radiograph, or will it be clear all over your, or
All over.
around your radio? Right,
Yeah,
it'll be
all over.
around your full radiograph, right? Typically, unless you have your radiograph like very offset for some reason when you're taking it, but typically you're collimating down and it will leave you like a nice little frame around that's clear, and that's because you collimated. Now, the reason why it's developed, so if you manually develop, you don't emerge, you maybe didn't emerge the whole radiograph
Right.
into the developer, and that's why it didn't change color. Okay, so the developer is what actually turns that radiograph into what you want to see, right? So you'll be able to see your image and, you know, the black background behind it and all of that, so that it develops the image for you. So what does fixing do?
Doesn't it
Makes it,
fix the developer on the,
Yeah, most
Okay.
definitely. Yeah. So if you develop your image and you don't put it in the fixer, you can still read your x-ray. It just won't keep that image there for forever or for a long period of time. It actually goes away pretty quickly within like a day or so. So all of that developer comes off and whatever, and we now don't have an image. So having a fixer is essentially like we are sticking that x-ray on there permanently. So I like to compare it to people like, okay, say you're doing your nails and you put your, you know, color coat on, that's the developer, but then you want it to stay longer, so you put a top coat on it, and that's the fixer, right? So, you know, the fixer is not going to change your image it's not gonna make you see anything that you wouldn't have seen before, but it's going to make it stay. So, all right, so that means that when you guys are doing, so say you need to manually process something, what would you put it in first, the developer or the fixer?
the developer?
The developer, very good, right? Because if you fix it right away, then you're screwed.
Right.
Yeah, so you have to put it in the developer first and then rinse it off. Okay, and then put it in the fixer, and then we rinse off the fixer afterwards, because the fixer, if you get it on your clothes, it makes a horrible mess. It's disastrous. All right. Okay, any questions on that radiology stuff? You guys are like, ew, radiology, we're done.
Beth,
Okay. Yeah.
if you don't mind, could I ask you? So, when it comes to the KVP and MAS, do they affect the radiograph in the same way? But are we talking about like the actual patient, the one that we're looking at, like when, you know, the bone or
Got
or
it.
are we talking about the background?
Right.
I
So
always get those two confused.
Yes. No, good question. So your MAS is going to be like how I tell people the background of your image. That's how I like to refer to it, is if you see the background of your image like really, really dark or really, really light, especially like if your background is gray, then you need to increase your MAS, right? We need to make that darker. If we're talking about the KVP is penetrating of your tissue, so that is your actual patient, or you know, you can say KVP is your patient, PE and patient. So however it makes you remember that. Yeah. So if your patient comes out too dark, right? Or the tissue that you're doing comes out too dark, then you need to decrease then your KVP, right? Or if your patient's too light, but your background looks okay, then we need to increase our KVP because we need to make it a little bit darker. So,
Oh my God, thank you. Yeah, makes
yeah.
sense. And now it's like clicking. I guess if it's just simple like that, I'm like,
Yes.
oh, okay, that makes total sense now.
I know I
Thank you.
learned like a fourth grader, so that's how I teach
Me
it.
too. Thank you.
Sure. So for dentistry, so knowing your terminology, like your directional terminology is really important. So like if we're talking about the lingual side of a tooth, it means that it's the inside of the tooth that is facing, it's closer to your actual, the actual tongue, right? If we're talking about buccal side of the tooth, we're talking about the side of the tooth that is closer to the cheek, okay? So making sure you know those directional terms. Obviously, if we're talking about, we wouldn't necessarily say the buccal side for like incisors, we'll call that labial side because that's actually closer to the lips. But if you said buccal side of the incisor, I would probably figure out what you're talking about. But typically, you know, our cheeks are going to be over here versus our mouth is right here and our lips are right here. So that's why I wouldn't say buccal. So, and then knowing, of course, what the maxilla versus mandible is, okay, and your right and lefts on your patient and stuff like that, so that we can correctly identify each teeth that we're talking about. So, the mineralized tissue that covers the root of the tooth is called what? Good. So the cementum. So just thinking of the root of your teeth, right? How does that root stay there or like is able to stay in the periodontal ligament, right? Yes, we have our periodontal ligament that's pretty tight on there, but we need to be able to cement down that tooth into that periodontal ligament. So it is covered by the cementum. Okay. Now, we were talking about the crown of the tooth. What's the mineralized tissue that covers the crown of the tooth?
Enamel.
Enamel, very good. So say you take out a tooth of a patient and you examine that full tooth. So the crown, and then you also have the root there. If any of you guys have ever been able to kind of like feel the root of the tooth, it isn't as smooth as the crown of the tooth, correct? It's a little bit more rough. Anyone ever feel a tooth? You're like, no, that's creepy.
Yeah.
Okay.
It is creepy.
But that's because enamel is not covering that root of the tooth. Okay. It's that cementum that's there, or the broken down cementum if you're taking out a really diseased tooth. So very good. So here's kind of our picture of all of that stuff. So as you can see, here's our enamel. It's nice and smooth. The cementum goes from here and all the way around. So again, it's more of that grittiness on there. The inside, so after we get down the enamel here, we're going to get to the dentin. And the dentin, if anyone has ever had like a cavity or a broken tooth or anything like that, it's not because you necessarily had root exposure that it hurts per se. Like if you have root exposure, it really hurts, but or it's really sensitive. But the dentin is actually pretty sensitive too. So it can be really sensitive to cold things. It can be sensitive to sugary things. It can be sensitive to basically anything, right? Anyone have cavities before? I'm sure a few have, right? So it's sensitive because we've gone through the enamel and now what is exposed is the dentin, okay? And then if you have root exposure, it can even be more sensitive and you can also get infections that way and stuff too, so that's not good. So we also have our periodontal ligament here. So the periodontal ligament is holding in that tooth as well. So we have a ligament holding on to something. And then we also have our cementin to hold in that tooth. Now, the apex of that tooth here is this bottom part of the tooth. Some people think this is the bottom, that's fine too, either way. But the top part of the tooth, bottom part of the tooth, And so that has all that nerve connection and also where the blood supply is coming from and stuff like that. Okay. Now our alveolar bone. So this is something that we also is important to look at when you guys are taking dental rads as well, is that, hey, how does the bones look like in our mouth? There have been numerous amounts of people who find like osteosarcoma in the mouth or some sort of neoplasia, I should say, in the mouth, just from dental rads, right? So it's a good way to even tell people too, like, yes, we are taking dental films, but it's making sure that we have overall great oral health, including, you know, the jawbone, stuff like that. All right, so the Trident number system, okay. So this is a way for us to be able to locate teeth and then also be able to share that information with other people without people getting totally confused, right? On each tooth. So every single tooth has a number and they are 3 digits. So the first number represents the quadrant that it's in, and then the last 2 numbers are the tooth that it is itself, on that side or whatever. So when we look at this, if you guys are like, I can never remember my 1, 2, 3, and 4, what I do is I take my left hand and make a C with it, and then I put that up to my mouth. And then I go 100s, 200s, 300s, and 400s, just around that C. And that makes you remember it if you have a hard time when you're first learning. Now, our deciduous teeth are different. So those guys are numbered completely different. So if you guys have a dog, a little tiny, let's say Yorkie, right? Those guys always have deciduous canines and stuff. You will say that you pulled or your doctor pulled the deciduous 504, right? That would be the right upper deciduous canine tooth, correct? Because we just go 1, 2, 3, 4, and then we go back 5, 6, 7, 8 of the hundreds. And that's how I count our deciduous teeth. Sometimes they have incisors that are kept behind that we have to pull too. So that's just a way for us to write it in the medical record that, hey, this is what was done. And then if we have to send them to anyone, or if we are looking back at the medical records later, we go, oh, okay, they had this tooth pulled before, and now we all know that, because none of us can remember every single patient that comes in the door, even if we tried. And so another way of remembering is the rule of 4 and 9. Anyone know what that rule is?
4 is always canine, 9 is always molars.
Okay, good. So 4 is always the canine tooth, right? And then the 9s are always the first molar. So whether you have just 1 molar or multiple molars, it's going to be your first molar that you have. So it's especially important when we are talking about cats, because cats are missing teeth, right? So we have to say, okay, so we have 204 is here. So I can count my 1, 2, 3, 4 normally. But what I'm going to do is I'm going to go look for that molar and say, okay, that's 209. I'm going to count backwards on my premolars. And so it'll be 208, 207, 206, 205 in a dog, but in a cat, they don't have this 205. So if I were to go 1, 2, 3, 4, they don't have this guy. Some people go, oh, 5, 6, 7, and then you're totally off in your numbering. So that's why it's good to just go, okay, I'm going to find my canine and my molar and then count backwards. And so when you go 208, 207, 206, even if you don't remember that cats are missing that 205, you can go, oh, well, one's not here. Oh, yeah, that's right. They don't have that 205 because this is my 204. Okay. So you just omit that for them.
Both, right? 105 and 205.
Correct. Yeah, they're missing 105, 205. And then on the bottom, they're missing that 405, 406, and then 305, 306. So that's where I see the most like numbering issues is with the premolars on people. And truly, it's going to help you the most if you remember your rules of 4s and 9s. Okay. Especially if your doctor's like, hey, can you take a picture of 208? And then all of a sudden you're like working on the wrong, you're like trying to get a picture of this molar here. And they're like, that wasn't the one I wanted. So you want to make sure you know.
Whenever you're doing the like the chart,
Yes.
felines are premolar 3 and 3, where canines are 4 and 4, correct?
So I'm sorry, canines are the 4 and 4, and feline are actually 3 and 2.
3 and 2.
Yeah. So they're missing on their mandible, they're missing that 5 and 6 on both sides. So 305, 306, 405, 406. But that's really good to know for sure. Definitely know your canine and feline formulas for teeth for the VTNE.
I can vouch for that.
So here's a picture of that for you guys so you can see. So obviously there's just more space, right? For our canines, they have bigger mouths to be able to fit all these teeth in here, right? So on felines, they have the molars, they only have 1 molar. Okay. And on our canines, it's 2 and 3. So 2 on the top, 3 on the bottom on both sides. Okay. So you might see in here on this like weird numbering scheme, some of us old people probably remember this, right? So if you have a canine, it's like canine 1 labeled C1 in there. Okay. So you may see this, and this is the only reason why I talk about it. It's not the Trident system at all. This was actually the numbering system before the Trident system came out. So we had to know this for school. But I like to tell you guys about it because you may get some medical records from some older vets or some older people in the field that still use the system versus the Trident. It's becoming a lot less common that you'll see. A lot of people have switched over to the Trident, but you may see it here and there. So not something you necessarily need to know for the VTNE, but just kind of be aware of it. So this is a super easy numbering system. So the way that you will notice it is that if you have a canine, they have 1 canine, right? So their first canine is listed. Since it is on the right side, they put the 1 on the right upper part of that because it is the right upper part of the mouth. All right. If you're on the other side of the mouth, it is the canine left side. So an upper left side. So you'll see the C and then the 1 in that upper left corner. Now, as you guys work your way down on the lower left, you'll see that the canine is C1 in that bottom corner of the left side, right? So it's just indicating we're going around the C of where that number is at. So you can say, okay, so that's the bottom, this is the bottom right, because it's the 1 is on the right side of the C and it's in the bottom. Okay. Now, same thing with like premolars as well. So even though they don't have those 2 premolars on the bottom, we go to P3 right away, and it's the 3 on the bottom right. So we put it on the bottom right. All right. So it's just a little bit of a differing numbering system if you do see it. But like I said, most people are doing the Trident numbering system. Anyone use this before?
Sorry.
Yes.
I've seen it. We don't use it. But Beth, I was gonna ask you, could you hear me?
Yes.
Oh, okay. So it's the direction is by how we're looking at the pet, right? Not their left and their right. It's our left and our right, how we're looking at.
Yeah, and this is where people get really confused, right?
Yeah.
So you have, it's your patient's right. So if you're looking at the patient, right, their right side is on your left side. Okay.
Yeah.
So we have to go off of their actual right side and left side. But when you are looking at the P itself or the C itself, it's the right side of the C or the left side of the C. So if you're looking at the patient, it's going to be
Looking,
opposite, but it's the way that your patient is. Yeah.
right. Okay, so it's, yeah, when we're using this, it's actually
Yeah.
right what we're looking at, but I know, yeah, the left or the right of the patient. Okay,
Yes.
makes sense.
Yeah,
Thank you.
of course. All right, so just so you guys know those, okay, so progression of dental disease itself. So this can be a little bit confusing for some people, and I feel like sometimes this is where like even our client education can be really, really helpful by just kind of describing like how dental disease is formed. It's formed pretty quick. It can be formed, I should say, pretty quickly. So bacteria in the mouth produces a biofilm like fairly fast, okay, which will then turn to plaque. So this biofilm that you get is kind of this like yellow, sticky type of film over your teeth. Maybe some of you guys are like, oh my gosh, I totally know what you're talking about. This is why I have to brush my teeth like 8,000 times a day because I can't stand that filminess on my teeth or whatever, right? But we typically can scrape away that film pretty easy within the first 48 hours. So like if you can brush your teeth the next morning, you're going to have that film on there, but you're able to brush your teeth and get rid of all of that nasty bacteria and plaque and stuff that is built up. Okay. Any of you guys kind of know what I'm talking about? Yes.
Yeah.
It's not, yeah, like no one likes it. So same thing with animals, dogs, cats, all of that. So this is why we really say to people like, try to brush your animal's teeth every single day if possible. And then people go, we can't do that. That's impossible. And even we are not the best at it. There might be a few of us that are good at it, but
I brush my cat's teeth every night.
well, you are the most amazing owner ever.
He lets me.
Yeah. And then, so after the first 48 hours, minerals and saliva will combine with that biofilm. And when oxygen is depleted, that's when you're really going to start getting some really nasty, like anaerobic bacteria, and that plaque will start to harden over time. Okay. So it hardens pretty quickly, where we aren't able to remove that stuff after about 10 days, like there for good. So this is why we really need to brush their teeth, or they even have like dental wipes now, which are fine. Like a lot of board certified dentists even say just doing the dental wipes is sufficient enough to do for animals, especially on your cheek teeth, because that's where they chew, right? So those are going to get the most type of plaque and buildup from. But if you can brush your teeth, that's even better, right? But they're like, however best we can do it. Now, there are things that you can put into their water, like that, like chlorhexidine-ish type of stuff, right? That would just be like if we use Listerine. It's not going to get rid of the plaque that's building up, but it's going to kind of wash away a little bit of that bacteria that's there. So it's not great, but it's not, it could be a lot worse. We could do absolutely nothing, right? So I already told you this, but let's see if you guys were listening. So the heaviest calculus deposit on dogs and cats' teeth are located where? Okay, perfect. So it is on the buccal surface of your upper cheek teeth. Okay, so if you think about it, especially like dogs and stuff and cats, is this buccal side has a nice big pocket for like food to just kind of sit in and all of that stuff. And they use those teeth to chew, especially like P4 and all of that. So even though we get, calculus deposits on that lingual surface of your lower cheek teeth, it's definitely not as heavy as you'll see in the buccal of your upper teeth, right? The buccal surface of your upper teeth. So a lot of us get really excited in dentistry when we get to see all that calculus and then we're able to crack it off really fast on the buccal surface of those teeth. It gets kind of fun, but when you look at the bottom teeth, they usually aren't quite as heavy. You might have some calculus there, but it's not quite as bad. Okay, our incisors, yes, we can get calculus on there, but it's not going to be as much as maybe your upper cheek teeth. And same thing for like lower canine teeth. Yeah, yes, our upper canine teeth can get pretty gross too, but again, remember, because there's like a little pocket there to place stuff that can deposit on there. And it's usually when we have a lot of calculus on those back cheek teeth that will start getting more and more moving upwards. Okay. So this is kind of what I was talking about of that hardened progression of dental disease. So after about 10 days, that plaque really hardens into calculus. And are we able to brush that away? No, right? And so even though we may see maybe like a Maltese and the owners are like, hey, can you brush my animal's teeth? Like, yes, I 100% can, but it's not going to help anymore with getting this plaque and tartar off, their calculus off, right? We can just try to prevent any more from forming, but even that's hard. So the only way to get rid of this is to actually do a full dental cleaning, which we'll actually talk about what dental cleaning is really called and what that entails. But not doing anything can cause infections because we're right close to that gum. And we start to have bleeding here, and that's going to get into, of course, our circulation and can become even worse. And we have deterioration of tissue, meaning that we can have recession of the gums. It can also deteriorate our jaw too. So even if you have, you know, if it's really, really bad and stays there for a long period of time, like our overall jaw health is not great. So some malocclusions that you'll see. So we have mandibular mesial occlusion. So that's an underbite, which can be a standard for some breeds, but in some breeds it's not a standard, right? So like our Chihuahuas and stuff, that's not a standard, even though I'm sure some of you guys are starting to see some more and more patients that shouldn't have an underbite come in with underbites or some sort of malocclusion that shouldn't be. And that could just be from poor breeding and stuff like that. Granted, this like little bully type of dog, this is probably his breed standard for him. Now the problem with this is if you can see these teeth, right, we should have a nice scissor tooth bite. And especially with this tooth, if we have this one jaw pushed back, it's going to have tooth to tooth contact, right? So you're seeing some of that here. You can probably see that this is going to have some contact. This 100% has contact on tooth to tooth, and so does this. So we don't have that appropriate scissor bite for them. Now, if you have a breed standard, they still might have that scissor teeth, but this is just pushed back a little bit. So it is a malocclusion, but it just depends on the severity of the malocclusion, right? So this one is pretty bad. They would have to actually try to fix that. So, and sometimes they just pull a tooth here and there if they really need to, but sometimes you have to actually truly fix that jaw in order for it to function appropriately. So performing dental treatment. So many of us say dental, and you'll catch me saying dental every once in a while. It shouldn't be called dental, right? We're doing more. Dental doesn't really describe what we're doing for a patient, and it's not a prophylactic thing. So we are actually treating dental disease every single time that we are going to do our treatment for them. So it's not a prophylactic thing. Sure, we might be prophylactically treating for other things like endocarditis and stuff like that by doing more cleanings, but we are not prophylactically doing dental care. So so a lot of people will say dental prophy It's not a dental prophy, okay? So really what we call it, and this one is kind of stuck the most, is COHAT. So it stands for Complete Oral Health Assessment and Treatment. So meaning that we are looking at the mouth, we are assessing the health of the mouth itself, okay? And then we're treating what we have assessed, right? So other terms that we have had to were OAT, so Oral Assessment and Treatment. And then we also have IOT, which is Interventive Oral Therapy. So this would be like if we had to fix that underbite that was creating issues, or if we had to, you know, do a root canal or something else to that nature, because we have to do interventive therapy to treat for something. So everyone using COHAT for the most part in your like records and stuff like that, or are you guys still saying dental?
I hear more of the prophylaxis sometimes.
Yeah,
still,
yeah.
but they do
So-
use the COHAT.
Good, good. And I think it's just getting ourselves out of that habit of doing it, right? Because we've been saying it for a really, really long time of, oh, it's a dental prophy or whatever. Now, granted, like if your CSRs and stuff are writing in, you know, like for the appointment, like, oh, it's a dental or whatever, like I'm not going to be like, no, you must call it a COHAT to all the CSRs. Like they have enough stuff to learn on their end that they can write in dental because we'll understand what that means. But in medical records and stuff, we should really be calling it a COHAT because that describes exactly what you're going to be doing. So protecting yourself. So this is actually one of my old coworkers who really, really loved dentistry. So making sure that we are wearing the appropriate PPE for our procedures. So for a COHAT, we should 100% have gloves on. Okay, I've seen people not wear gloves and I'm like, oh my gosh, I can't believe that. We should have a mask. We should have goggles or like protective glasses, a cap to protect our hair, and then a jacket or gown, or just different scrubs that we're wearing for our COHATs. So reason being is that we are scraping away at these teeth with an ultrasonic scaler, and there's water spraying everywhere and things are spraying everywhere, that you can inhale all of this stuff, right? You can inhale this bacteria that's all wetted and whatnot. You can get the stuff in your eyes, you can get it on your hands, you can get it in your hair or your scrubs even. And so if we are having this gross bacteria all over us and then going to touch another patient or even just ourselves, that, you know, we can get stuff in our eyes and whatever, we're all susceptible of getting sick from this nasty bacteria, right? So this is why we protect ourselves going into surgery, but this is another reason why we should protect ourselves in dentistry, because stuff can go everywhere. So if you guys are number one doing your dental procedures, or COHATs, I should say, in surgery, you should not be, right? Because unless you are thoroughly cleaning that surgery suite afterwards, it is really gross. So, because you're getting bacteria everywhere, and that is not good for surgical procedures. So moving your COHATs outside of that surgery perimeter in its own room is totally fine. And if you absolutely have to in like a treatment area, that's okay, but try to move it away from like other patients and stuff and an easily cleanable area. Okay. I've known some people to have gotten like pink eye because of doing dent or COHATs, and because they didn't wear their goggles or glasses. And so it's important for all of us to protect ourselves. The equipment that we use, so we have, if any of you guys utilize something similar to this, is what you'll kind of see. So you'll have your ultrasonic scaler that's right here. Okay. We have our own like hand scalers as well that we'll talk about. But our ultrasonic scaler is going to get off the most of our calculus and stuff on our teeth. We have our low speed handpiece versus our high speed handpiece. So the high speed handpiece is going to be like for drilling and cutting teeth. The low speed handpiece is for polishing and then any kind of like root canal prep and stuff like that if you guys are doing root canals. We have a 3-way syringe, so that's going to have air. It's going to have water, and then you can use both at the same time, which kind of does like a spray. And then sometimes you'll have a light source too. So sometimes we'll have a light source on our ultrasonic scaler. And then also on our drill, which is really, really nice. It's just an extra light to help see in the mouth a little bit better. So I personally like that. So if you guys can afford to get that on your machine, it's a little bit more pricier than not having it, of course, but it's really nice to have. Another thing that is becoming a little bit more common that you'll see is using some sort of type of suction in dental, or I should say COHAP procedures, right? See, I'll say dentist all the time. In our COHAP procedures. So you can use like your regular suction machine and try to just keep suctioning out the mouth from, you know, water and also blood that might be there and stuff like that too. Just like when we're going to the dentist, right? They always have like a little section there for you. So utilizing that, because yes, we should have our patients intubated that entire time, but it is nice to just remove as much moisture out of the mouth as possible so we really don't have aspiration, right? Even though we'd like to think that our ET tube is nicely inflated and perfect and all of that, there's still a chance that they can aspirate a little bit as well. Hopefully not, but maybe a little bit. So having suction is always nice. So other common equipment, so these are like our hand instruments. So we have our probe and explorer, usually on, sometimes you'll see them separate from each other, but usually you'll see them, one side has the probe, one side has the explorer. So what does the probe do?
It checks the depth.
Measure.
Good. So yeah, we're checking the depth of pockets. So I would say we're probing for pockets around the teeth. So P&P, right? So you're probing for pockets and you're looking at the sulcus depth. So what should our normal range be for a dog?
A dog is 0 to 3.
Okay, good. 0 to 3 millimeters, right? So anything more than 3 millimeters is a cause of concern, or like a gingivitis, another possibility of gingivitis or something like that. Doesn't mean that, oh my gosh, they're 4 millimeters, we have to pull that tooth. Absolutely not. Because by doing our COHAP procedure, our hope is that we have less gum recession. It will regenerate back, it'll come back. It'll grab a hold of that tooth a little bit better. And when we go to check our teeth the next time, that maybe that has improved, right? Now, if we have a really mobile tooth and the sulcus depth is like, you know, 6 or 7, then we might have to remove that tooth, right? Because we have a mobility going on with the tooth and stuff like that, and we may need to take it out, okay? And even sometimes we leave it if it's slightly mobile, but it just always depends on how like the overall health of the tooth is.
So Beth, if a dog with a hypergingival, you know, and it's like a 5 millimeter
Yes.
depth, would that, I mean, depending on the health of the tooth, but if it is pretty deep because of that, do you take it out or you consider it normal?
So we wouldn't consider it normal per se, but there might be some things that we can do before having to remove that tooth. So we'll talk about root planing is one thing, right? So really making sure that we have all of that calculus out from even underneath the gum line, because our overall hope is that it continues to get better and better over time. Now, I think the biggest thing is like, if the tooth is really mobile at 5 millimeters, then maybe, yeah, we need to consider taking it, because underneath the gum line could be like root degeneration, or maybe there's an abscess there or something like that. But, you know, looking at the overall tooth itself, so we may be like, oh, it's 5 millimeters. let's make sure we take a really good film of this tooth to make sure that the tooth is okay. And then the doctor will say, yes or no, we want to take it out or not. So it really kind of depends, but it's the first thing that you look at to be like, ooh, this one doesn't look quite right.
Okay, thank you.
Yeah,
So for dogs, it's 0 to 3 and cats, it's 0 to 1, right?
correct. So cats are 0 to 1. And again, that means that if you might have 2 or, you know, a 2 millimeter or 3 millimeter, it doesn't mean that we necessarily have to take that tooth out, but it should really prompt us to want to investigate that tooth even more. Would we love to have full mouth radiographs in all of our patients? Absolutely, right? But I know that not every single hospital is there yet. So by doing some of these things for, you know, our assessment on them, it can help us lead into the direction of finally getting there to, you know, be able to take more and more radiographs. So what about the Explorer? What does the Explorer show you?
I said that you run it through the tooth, the enamel, to see if there's like a, I guess, plaque or little things on the tooth.
Okay, good. Yeah, so not necessarily plaque, but we are running it around the tooth to see if there's any like sticky spots on that tooth. And sticky spots can mean that we have dentin exposure. So do dogs and cats typically get a lot of cavities?
No, not really.
Yeah, not that often, right? Or not as often as we do. And that's because we eat a lot more sugar than animals. So it will break down our enamel a lot more. But animals do chew on a lot of things. So they will get dentin exposure from a lot more fractures and stuff. And so even though we might see some bigger fractures, sometimes we don't see like small little tiny fractures here and there. From chewing on a rock or chewing on a stick or something to that nature. So that's why it's important to explore those teeth and see if there's any sticky spots on that. Now, the hand scaler, okay, so we do ultrasonic scaling, but we also have hand scalers. So yes, you can hand scale all the teeth if you absolutely want to. That would take you forever. But say your scaler's broken and you do have to hand scale everything, you can, right? But why might we use a hand scaler if we already have ultrasonic scalers?
The ultrasonic scaler won't get everything.
Okay, it might not get everything, right? So our hand scalers should be a little bit sharper in order to get the little tiny bits and pieces off that we might not have been able to get with our ultrasonic scaler. So it is good to be able to look over the teeth and say, okay, like on the crowns of the teeth, is there anything extra that I am seeing here that I can just really, you know, scrape away, add a little bit better, you know, get in all those grooves and stuff like that. Now, what about curettes? What is the difference between our curette and our scaler?
Don't the curettes like go different directions against the teeth?
Okay. They can be in different directions. Like you'll get all different types of scalers, so they can be in different directions for you. But the anatomy aspect of a scaler versus a curette, what is different?
Can't the curettes go subgingival and the scalers cannot?
Yes, good. And why is that?
Because they don't have the sharp tip.
Good. Yeah, so they don't have on the top of your curette, it's curved, okay? And so when you go underneath the gum line, it's not going to cut the gums then because it's curved at that top. So it has 2 sharp points on the sides of it to be able to get that plaque off. But if your scaler is kind of like a triangle, there's 3 points to that scaler. So if you go underneath the gum line, you're going to cut your gums up pretty bad. So it's definitely not good. So we can use those hand scalers on the the actual teeth itself, like the crowns of the teeth. But if you're going underneath the gum line, we need to use our curettes. So just remember curved curettes. They're curved at the top, so that you can't cut the gums.
So this, I'm sorry, so the scaler can cut, the curette cannot.
Correct. Yeah.
And
Yeah.
and can you please tell me which one is which?
Yeah. So on here, interestingly, I don't have one. But they, like I said, they both look very, very similar to each other. It's just that when you look at the top of the curette one, it's going to be curved.
Okay.
Okay.
I'll look them up. I just, yeah, because you know, I'm not in the, I don't know I know the probe and Explorer, and I can guess, you know, that
Yeah.
some of them are. Okay, thank you.
Yeah. All right. So our elevators, we have all different types of elevators that you'll see. So in here in this picture, you'll see like here's an elevator there. There's an elevator right here. And then here is also an elevator that we can use as well. And so it all depends on your tooth size, getting around the tooth and stuff like that. So they're all numbered with what size they are. So if your doctor is like, I need a size 3 elevator, you're gonna look at the handle usually and it'll say on there like that it's 3 millimeters or whatever. Or if they want a 2 millimeter one, they'll grab the 2 millimeter one. So granted, your smaller ones you probably would use for, you know, your actual like incisors, and maybe like your 3 is kind of your standard one that a lot of doctors like. And those kind of work a little more on the premolars and everything. And then they can go larger and larger from there if they really need to. And the idea behind the elevator is to do what?
During extractions, it helps loosen the tooths.
Good. So it helps loosen the tooth. How?
Loosening it from the bone.
Okay, not necessarily the bone, because remember the tooth is not connected to the bone.
Does it elevate the gums so that we can get access?
Okay, so you're gonna start with the gums, but you're really working at the what? What's holding the tooth
Periodontal
in?
ligament.
Good, the periodontal ligament. Very good. So really what we're doing here, what your doctors are doing, is that they're stretching out that ligament, because sometimes the teeth don't need a lot of stretching, right? Or the ligament doesn't need a lot of stretching to get that tooth out if it's a really diseased tooth. But sometimes we do have to remove maybe a healthier tooth that's like fractured really bad or whatever. And your doctors get really upset because they now have to take out this nice healthy tooth other than this fracture, and maybe it's like a canine tooth, which we all know canine teeth are not fun to extract, right? Because it's a really big tooth. So they then have to stretch out this periodontal ligament that's really, really tight on that tooth, right? So it takes a lot of like arm strength to do that. And so some of us remember from a long time ago, before veterinarians started to do like flaps for teeth and cut the roots in multiple, you know, cutting one root at a time out, that they used to just use elevators, right, to extract teeth. And not only were they leaving behind roots, they're leaving behind the roots because that periodontal ligament wasn't stretched very perfectly, right? So now by making that flap there and cutting the teeth into sections, they can work on one particular root at a time, creating less trauma, even though we think of, oh my gosh, you're cutting the gums, so that's a lot of trauma. Well, think about stretching out that ligament and then holding and pushing on that patient's head and face and all of that for a long period of time, sometimes like an hour to get out a tooth, right? That can create a lot of soreness for them. So by creating that flap, yes, we're making an incision and we're having to suture it up, but it's a lot less like trauma for them actually by pushing on their face and all of that stuff. So they will still use the elevator because they'll have to elevate out that each individual root, but they definitely don't have to do it quite as much as if they're trying to get all 3 roots out at the same time or 2 roots out at the same time. So we have calculus, forceps, and extractors. Sometimes we call them rongeurs too, because we have rongeurs for our bone surgeries and stuff. But those are these guys right here. So essentially you can crack off the calculus with that, yes, but really it's an extractor to extract the teeth once you finally like loosen that periodontal ligament. Okay. I wrote on here no gags because I'm talking about the spring-loaded gags. All right. Can you guys imagine if you had a spring-loaded gag in your mouth? It's pushing your mouth open for a really long time. It's putting a lot of pressure on the muscles in your face. And so you can absolutely like hold the mouth open and create a mouth gag that is not spring-loaded. So sometimes people will use like a syringe and cut two ends of the syringe off and then hold the two canines that way to just kind of keep the mouth open. If they needed to, or just use some gauze is fine too, to like kind of make a gag to keep the mouth open a little bit, but just not spring loading it open because that spring puts a lot of pressure on those muscles in the face.
It also
Right.
can blind cats.
It can, yes, very much so. Yes. So, and that's from putting too much pressure on the nerves and stuff. That'll be really bad. Please don't do that. So yes, a lot of practices still have them and they don't want to part with them for some reason because we all are a little bit of a hoarder in the veterinary field. But I would ask people all the time, like, okay, I see that you have mouth gags here, but do you use them? They're like, no. I'm like, then throw them away. If you're not going to use them, throw them away. So probing and charting, it's really difficult to do in a quick basis if you're just doing it yourself. So it can be nice to have a 2-person deal so that when you're probing around that tooth, whether it's the 4 to 6 points around the tooth, you can have a system where you're just calling out numbers so that they can record those numbers for you. If you have to do it by yourself, that's fine. It's just going to take you a little bit longer. And then, like I said, probing and exploring can be a really, really important part of that job because it's going to tell you a lot of information about that tooth before you're actually seeing images of it. So we're looking at the gingival depth, mobility, and then what is furcation? Other than a kind of cool word.
Is it the stages of periodontal levels?
Okay, so it definitely is going to show you periodontal disease because we're not going to have furcation without some sort of periodontal disease there. But furcation is if you have gum recession that goes past where your roots are starting to be exposed of that tooth. And it's like if you're able to take your probe and put the probe through those roots of the teeth from the outside. I think I have, do I have a picture of it somewhere? So here's furcation. So see how our gums are recessed back? So we have that here too. So if we're able to stick our probe in and say, okay, those are the roots of the teeth and I can get my probe right in that, that's like our stage 1, right? We're starting to find a space for that probe to be where it shouldn't be, right? Our stage 2 would be like if we put our probe through, but it doesn't come out the other side. Okay. So say that might be this guy. This one might be a 2 or a 3. I can't tell because I can only see one side of the tooth. And then stage 3 would be like if the probe can go all the way through. So furcation is good for us to note because how well do you think that these teeth are held in compared to maybe this canine tooth at the moment, or this premolar right here that's not showing any furcation? Do you think this tooth is going to fall out faster than this tooth?
No.
Yes, right? Like this one might fall out first compared to this one because our gums have recessed So has the periodontal ligament, because we're starting to see the roots of the teeth. So this tooth might be a little bit mobile at this point compared to this tooth that looks pretty anchored in the mouth, right? Or the canine tooth that looks pretty anchored in the mouth. So it's going to tell us a little bit about more about the tooth, that like, hey, this isn't very healthy. Now, if it's not mobile, you know, like this is a one rooted tooth, but you really can see that gum recession, right? Or here, you'll see that furcation just starting. Is your DVM going to say, oh, we got to pull this P4 because we see a little gap right there? Probably not, right? They're probably going to go, ooh, let's see if we can clean up this tooth really well, do some root planing to get this really cleaned and all of that. And they might even do like a little bit of antibiotics in there and stuff too. And then recheck your cohat, you know, maybe 6 months down the road or the next year, and really try to get the owners to come back to see that we're getting that gum growing back over that tooth and it's becoming a little bit more healthy. Now, this tooth itself here, so this P2, it's probably getting to be a little bit mobile. We see that there's some bleeding going on. It's probably causing some pain for that patient. So this one's probably going to be taken out due to multiple factors, right? But your doctor's going to say, let's get a radiograph of that tooth and say it's really stuck in there. They might say, the owner, we can get them to come back. Let's really clean up that tooth and try to save it as much as we can. So same thing with this tooth here. So obviously this isn't a cat, but if this tooth is pretty anchored in, we may leave that and see if the tooth can, or I'm sorry, the gingiva can grow over that. If it is mobile, we probably would take it out. Right. So, let me get back to where I was. All right. So, calculus index, that's where calculus index, and then our periodontal disease score is telling us like how bad is the periodontal disease. So a lot of times we'll just look at calculus, right? And we'll be like, oh my God, that's a ton of calculus on those teeth. But for periodontal disease score, we're looking at not just calculus, right? We're looking at actually the overall health of the mouth. So we may have a patient that has like not that much calculus, but for some reason has really bad periodontal disease. So we have to grade it based on that, okay? You might have a patient that has like a ton of calculus, but for some reason is not going to have a horrible periodontal disease score because everything looks pretty good underneath. Or not as bad as you think that it would. Like, gosh, I've seen some patients that they have terrible calculus and we clean it up and they had no teeth removed, right? So, which is great. But then there's others where we, you know, take off the calculus and the only thing holding those teeth in are seem to be the calculus. So everything's coming out. Gingivitis index too. So how bad that gingivitis is. Usually we go off of periodontal disease score though, but you can also just indicate how bad the gingivitis is if we need. So taking dental radiographs, so we have parallel technique, which is what we use for which teeth?
Incisors, the canines.
So parallel technique is where we're
mandibular molars.
Okay, so mandibular molars, very good. And maybe P4 if you can get it, right? So all of those back teeth on the mandible are going to be parallel technique. Everything else in the mouth is some sort of bisecting angle, okay? So that's where people get really confused because they're like, oh my gosh, I don't know which one's parallel or which one's bisecting. Well, parallel is the only ones in the back mandible of the mouth. So if you're doing incisors on the top or incisors on the bottom, it's going to be a bisecting angle. If you are doing molars on the top, it is some sort of bisecting angle, right? You just have to get the angle right, that's all. but everything else, or I should say, but the mandibular molars and maybe P4 is going to be parallel technique, meaning that you're putting the film in the mouth parallel to that tooth, and you are going to take your radiograph straight on to your plate. So bisecting angle looks like if we have, so say this is an incisor tooth, right? It kind of looks like an incisor. We're going to place our film in the mouth. And this is the angle of our film. We are going to also use the angle of the tooth's axis. So incisors seems to be pretty easy to do because they're like pretty much straight up and down. And so we get that this angle here, right, of our film and our tooth. So I say follow the root of the tooth is your angle. All right. So because we don't care about what the film looks like with the crown, because we can see that from our naked eye. We don't care what we don't have to actually take a photo of that, an x-ray of that. But we want to get the angle of the root because that's what's the important part to be able to look at on our film. So we have this angle here, and bisecting angle means that we bisect this angle that we've created. So we cut that in half for our incisor. So it's a 45-degree angle. And then we're going to take our beam and we're going to go perpendicular. We're going to shoot our radiographs perpendicular to the bisecting angle. Okay, so not perpendicular to the film like we do on parallel angle, but it's the bisecting angle of that. So it's casting a shadow onto the film when we take it.
So perpendicular to the tooth, right? Yeah, that's what you just said.
So we're doing perpendicular to the bisecting angle. So not necessarily the tooth. Yeah, it's of the bisecting angle. So when you hear people say, you know, okay, we're going to do, you might see this in practice where they're like, when we take a film of the, of the incisors or whatever, we go at a 45-degree angle, right? There's measurements on your actual, on your actual radiograph machine for your dental rads that will give you the angle. And essentially it's measuring this bisecting angle for you, and then it will throw that cast. So it's just an easier way for you guys to be able to learn those angles over time versus having to do the bisecting angle and like kind of draw it out for each tooth, right? But it's understanding what what those angles mean, that it's the bisecting aspect of what you're measuring. So if you're doing like a canine tooth, it might be at a 70-degree angle, right? So you're cutting this angle a little bit sharper here, and then you bisect that. So if you do see some videos and stuff of how to do like dental radiographs, they will tell you those angles, or you may see it in like your book that says how to do bisecting angle a different way. That's what it's actually telling you, right? But at least know what bisecting angle means. Okay, so we're just going to finish up a couple of things because I know we're over, but you are looking at your dental radiograph and notice that the tooth is elongated. This happened because the beam was perpendicular to what? How do you elongate the tooth? So rather than the beam being perpendicular to the bisecting angle, so I already took one away. What is it perpendicular to?
Oops.
All right. So those of you that said tooth, you are correct. So if we are perpendicular to the tooth, right? Our film is kind of laying flat. So if we go perpendicular tooth, it's going to cast that shadow even longer than it should be. If you go perpendicular to the film, it's going to make your tooth look really, really short, right?
So the tooth, it'll be elongated, the film, it'll be shortened, right?
So if you are looking here and you take your beam and you go perpendicular to your tooth, right? It's going to elongate the tooth onto your film because it casts that shadow onto the film. So it's going to essentially hit your tooth and then elongate that tooth out onto your film because this film is going outwards, right? So it's making that tooth look longer than it should be. Now, if you are doing your beam right and going perpendicular to the film, okay, so your beam is going more like this to the film, perpendicular to the film, it's going to make your tooth look shorter because it's casting the shadow onto the film really, really short here.
Thank you, thank you.
Yeah, I'm like, I always need a visual, so.
Yeah, oh, me too.
So non-screen film. So this is if you guys are using some sort of, well, for this would be like these are actually if you're dipping your film still, so doing manual processing. But we do have some digital processing that have different size films that you can use too. So if you are using some digitals that you can put into your digital machine after you do it, which I actually really like those a lot for multiple reasons, but you're able to kind of use the appropriate size film versus some of your digital machines only come with one size film, which can make it hard to see things. What I do like about some of the newer digital ones that have these like little reusable films is that they're really, really thin. So sometimes if you have a really good dog and you need to take a image really quick, you can do this with little to no sedation. If they're really good, and they will hold that film in their mouth because again, the reusable film is viable and that type of stuff. And when you're really good at it, you're able to take certain films without having to use a lot of sedation if you don't need to, if it's like on an emergency basis or whatever, or you just wanted to take a look at something. So what's important to note is that the larger the size, it goes up in that size. So 0 is for like really, really small creatures. And then you can go up from there. Now there is a dot on those films, and then also a dot on any digital film too of like how it should be oriented in the mouth. I have to fix what this says, but the dot should be always facing rostrally, so out of the mouth. So don't read off of that. But that is our way of indicating the right or the left side of the mouth or upper or lower part of the mouth. Okay. So finding out where the dot is on your digital rads is really important. It's might not be necessarily where the cord is, you know, of your film, but it might be on the other side or whatever. So just take a regular film and look to see where that little dimple or dot is. And that's how you should face it into the mouth, out of the mouth. So if you guys are taking films and dipping them, this is what I wanted to show you guys too, is that if you are doing that, these are all the things that come in those films. So this is the film itself. It's kind of like this greenish, blue, light gray kind of thing, and it's a little bit more slippery. So you're gonna grab that, and then you're gonna, here's that dimple for you so you guys can see. And then this is all extra material that you just throw away after the end. So essentially, before you open it, you have a lot of protective covering over this film so it doesn't get exposed. All right, so you essentially peel these open, and then in your like little dark room or in your chairside dark room that you have, and then you put it straight into the developer and then go from there. So here's that chairside developer. So maybe you guys have seen it on the shelf somewhere, you know, for a cold rainy day. And you'll have 4 different little containers in there. So when you have the 4 different containers in there, you'll have the developer, you'll have a thing of water, your fixer, and another thing of water. So you just go through each to develop it. So we want to do about 30 seconds in the developer, about 15 seconds in the water to kind of rinse everything off. In the fixer, we do at least a minute in that fixer, and then we rinse off that fixer. Once we look at our image, then we can look at our image and be like, oh, that looks great. Or no, we need to retake it. We put it back into the fixer to fix it for longer. And then we clean it off. So we want to keep it in the fixer for a little bit, as long as we possibly can. A couple minutes is fine. And then this is what a full mouth radiographs look like. All right. So what I'll do is I will post the rest of these slides for you guys, so that you can see what like gingivitis is and unpurification and all of that. But if you guys have any questions, definitely let me know.
Where will you post those?
I'm gonna put these on Moodle, and then I'll also put them on the Facebook group page too, so you guys can see them.
And is there a specific Facebook group?
Yes. So since you guys are in the course, we have our regular VTNE prep pages for anybody who wants to join. And then there's also one called VTNE prep crash course. That one's for all people who are like currently in the course and taking it, so that you guys can like ask questions for one another and stuff like that throughout the course. And then it's just a little bit smaller because the group page, the big group page is really big.
So where is that? Where do I find that?
So just go to your Facebook and then just type in the search like VTNE prep crash course, and it should pop up for you. And then also it should be in the email that I sent you guys initially, saying like, welcome to the course. And then it should have the link in there on how to.
I'm on there now. VTNE crash course, prep crash course.
Yes.
I need to join it.
Yeah.
Thank you.
Sure. All right. Any other questions?
No.
Awesome. Okay. All
It
right.
was helpful how you did the class today. It was very helpful looking at those
good.
slides. Thank you.
Good. I'm glad. I mean, I'm sure you missed my drawings, but that's okay.
No, we enjoyed those too.
Yeah. All right. Well, I'll talk to you guys next week on our study session. And then if you guys have questions, let me know throughout the week. And I will talk to you all soon.
Thank you. Have a great
Yeah.
weekend.
You too. Take care.
Bye.
Bye.